Hi everyone. I'm here with the EUSRFA from Taewung. We have a model made of, what is it again?
Pork loin.
Pork loin with a lesion in there that we're going to demonstrate ablation with. So, can you find the
Yep.
lesion? There we go. So there's our lesion, and that's a nice model of what you would consider a neuroendocrine tumor in the pancreas, which this is very useful for ablating. EUSRFA can also be done for ablating pancreatic cysts. Do we have our needle? You can show the...
Do you use color flow or Doppler prior to delivery?
So we would use color Doppler to exclude any vessels, in the path of the needle tract. Some of the studies have shown some benefits using contrast-enhanced EUS, although I haven't had the opportunity to use that yet, to identify the lesion and its borders a little better and to identify areas to treat. But the nice thing about this system is the ablation catheter is built into the needle. Oh, there we are. So there's the needle coming out.
How do you determine the length of the needle depending on the tumor size?
So they have 3 different sizes of ablation zones, and I think we would use the smallest one, which is what, 5 millimeters, for lesions around anywhere from like 5 to 8 millimeters, and then kind of go up from there. And for some lesions, you can even do 2 or 3 ablations if it's a larger lesion. So, like I was saying, the ablation's built into the needle, so it's nice to just puncture, and once you're in, you don't have to advance any other catheters or anything through there. And we can go. And you're going to start to see it bubble. That's how we know it's working and ablating.
Do you watch the patient after for pancreatitis or admit them or?
I don't know if I have a fixed protocol yet, but I don't think definitely don't have to admit everybody. Probably watch them a little bit longer. I've read in some studies they've been giving rectal indomethacin like for pancreatitis prevention like we would in ERCP. So I don't know the true benefit of that, but it can't hurt, so that's something to consider.
How long do you ablate?
Well, the system will ablate until it reaches a certain impedance, and then you know that the tissue's been burned. I don't know if someone can explain that better than me, but
So 500 ohms.
okay. And then you would, like I said before, you could find another area if you feel like it's a larger lesion, and maybe you need to do some more ablation. But
You want to do another ablation?
yeah, let me get in there a little better.
For a pancreatic neuroendocrine tumor, when would you re-image the lesion by CT?
Okay, go ahead. You can ablate there. So I think that's a very good question. It's an evolving field. So what we're hearing now is to wait even longer to do follow-up because there can be delayed effects from these ablations. So 6 months or even a year later. And most of these lesions are low risk to begin with. So there's no harm in waiting a little longer to do your follow-up. And if you still are concerned about viable neuroendocrine tissue, you can always bring them back and re-ablate.
Other indications other than pancreatic neuroendocrine tumor?
So pancreatic cystic lesions, IPMN, in those you would want to aspirate the fluid first to try to get the wall partially collapse and then ablate the wall of the lesion. And it's probably some studies underway in adenocarcinoma, but I think the challenge there is how would you ablate a larger lesion, but there may be some palliative benefit.